All right, welcome to Module 5, where we will be talking about randomized controlled trials. In this module, we will be figuring out what is internal and external validity in terms of randomized controlled trials and how do we maximize these. We'll describe the randomization process and blinding methods for randomized controlled trials. And then we'll use these skills to analyze randomized controlled trials for their validity and their bias. Here's a case that we're going to kind of use as a tool throughout this lecture. The clinical question is, can pharmacist interventions improve hypertension control in non-Hispanic black men? And why do we need to do this study? Because limited enrollment of this population creates a significant knowledge gap. And we don't know. Can pharmacist-led intervention actually improve outcomes in this population? So we need some better designed studies, some stronger evidence to actually be able to implement this in practice and get reimbursement and just make an impact on this population. Here's the framework for what we'll go over in randomized controlled trials. First, we'll look at validity types. What is validity, internal and external? We'll look at blinding approaches, single, double, triple blind, and what randomization methods and the most popular ones that are used in randomized controlled trials. Here is our trusty hierarchy of evidence pyramid, and you can see randomized controlled trials fall right below systematic reviews and meta-analyses because randomized controlled trials are really the gold standard for determining causality. Let's kick it off with validity. So what is validity in clinical research? Validity is the degree to which a study's findings can be deemed correct and trustworthy, and it establishes confidence in the conclusions drawn from the research. So basically, how valid it is, how true it is. And validity can be broken down into internal and external. I know we mentioned this in a previous lecture, but here it is again. Internal validity means whether the outcome can be really truly attributed to the intervention, meaning, is it causal? Okay? It addresses the question, was this study conducted correctly? And it requires eliminating all the biases, confounding factors, and random error, at least minimizing them as much as possible that we talked about in the previous lecture. External validity means how well the study result applies to the population at large. Can I apply these findings to my patients? And it considers whether the results can be applied universally or only to specific patient populations. How does one maximize internal validity, meaning the effect you're finding is actually true? And here we use control groups, right? So we can compare. We have a comparator group. We always have comparator groups of the intervention to something. Generally, it's placebo, or sometimes it can be an active treatment control, and this helps to know whether the effect we're seeing is due to just regression to the mean, random error, or if it's actually due to the intervention. We can do patient matching through randomization to make sure the groups are equal to begin with, and we can reduce the chance of confounding, right? We use objective outcomes, meaning that we have to use concrete measures, not that are minimize subjective analyses, minimize subjective self-reported outcomes, concrete objective measures that we can then confidently say are affected by our intervention. And then finally, population selection helps reduce that bias and confounding. We carefully craft our inclusion and exclusion criteria to remove patients that could confound the results. So, for example, excluding hemophilia patients from aspirin trials because they're at higher risk of bleeding, so that could confound our analyses to see if aspirin increases the risk of bleeding. How does one increase or enhance or maximize external validity? Right, this is having our results applied to the population at large. And that would be having a broad study population, so including diverse ages, sexes, people from multiple parts of the country, sociodemographically, studies limited to specific populations like VA studies in older men have reduced external validity, and that's a natural thing you'll see. We want to represent different types of study settings, so those different parts of the country could have urban and rural hospitals, okay? And we also want to have interventions or treatment regimens that are practical, that can actually be applied across the country and not just at a specialized medical center like Detroit Medical Center or University of Michigan, but can be applied at very small medical centers in the middle of the country or somewhere else in the country that just doesn't have the resource capabilities that maybe a large metro center like Detroit has. Here's a great learning point in life. Everything has a trade-off. You'll hear me say this a million times because everything indeed has a trade-off. No decision in life, I'm not even just talking about, here I am as your dad in this class. Every decision you make in life will have a trade-off, okay? Everything has an ebb and flow. Everything you do today might affect or has to be done in consequence of not doing something else today, okay? So the same thing applies to internal external validity. You might be able to maximize internal validity, but that's going to be at to sacrifice external validity, okay? So strict inclusion criteria, that'll enhance internal, but it limits external. Narrowing the patient population, again, enhances internal, limits external validity. You could have a more controlled environment. This might help increase the accuracy of your study, increasing internal validity. But again, it might reduce external validity because not all places can do what you're doing. So you need to find the optimal balance between internal and external validity to make sure the result you're finding is as true as possible but can be applied and is useful for all patients with the condition that you're trying to study. We've talked about internal external validity. Now let's transfer over to blinding in clinical trials. Essentially, there's, for the most part, 4 different ways you can blind in a clinical trial. You can not blind, called open label, where everybody knows what's going on and patients know what they're getting. And maybe you're doing this because it's an early study or because you can't blind. If you're doing an acupuncture study, although they have sham treatment, it's very difficult to blind acupuncture. And you can see this often in the literature, and it comes with certain limitations and biases and preconceptions that might limit the trueness of your results, or at least have some sort of caution in the interpretation. You could have single-blinded studies where only the participants don't know their treatment. Okay, this reduces the placebo effect, but still allows for investigator bias that we learned about. You could have double-blind, so both participants and investigators are blinded to the treatment status, and so this is good because it increases the validity of the findings. Or that you could have the best yet, which is triple blind, meaning participants, investigators, and those people who analyze the data are unaware of the treatment allocation. So when they do group comparisons, the statisticians just know it's group A and B. They don't know what they got. And so it's often implemented. This is actually commonly used as still double blind in the literature, but really it's a triple blind, and that's the best way to do it. To further increase the robustness or the validity of our randomized clinical trials, we always want to use those objective endpoints we talked about. So we want to make sure that we are trying to measure something as directly and without subjective bias as possible. Okay. So some examples here might be a 2-minute walk test, which is a measured distance. That's an objective measure. Mortality, it's a clearly defined event, either happens or it doesn't. Or pneumonia has a specific diagnostic criteria, which are either met or they're not. Okay, and this reduces the impact of patient or investigator biases on the study results. You can also have surrogate endpoints, okay, because maybe you can't measure something directly. And this means you have to measure something indirectly, like someone's risk for a heart attack. How do you do that? You have to measure something indirectly through LDL, okay, for cardiovascular events. You could do viral load for disease progression, or tumor size for survival in a cancer study. And validity for validity, surrogate endpoints must have a strong established correlation with the clinical outcome. So basically your surrogate endpoint is based on previous studies that have shown a strong chance of a causal association between your endpoint and whatever outcome you're interested in. Almost always in randomized controlled trials, when we go over these studies in this class, you'll see that they list primary outcomes and secondary outcomes. Why is the primary outcome really important? Because that's generally how the study is designed to make sure it has enough power, big enough sample size to actually meet their alpha cutoff, their power, to know if the finding they're going to report is actually not going to give you either a type 1 error or a type 2 error, meaning that it has lower power. Okay? And so That's always important because we can be assured that whatever the finding is with the primary outcome, the study was generally powered enough to confidently report that, versus secondary outcomes, well, really useful and really clinically important, are not able to have the confidence in their outcomes as the primary outcome because they weren't designed for the primary outcome. So that's the difference between a primary versus secondary outcome in randomized controlled trials, which is why so much emphasis is put on primary outcomes rather than a secondary outcome. Moving over to how we randomize in clinical trials, you could do simple randomization, right? Just flipping a coin for each patient. And so this is a good and simple way to do it, relatively straightforward, but it could, depending on how large your sample is, lead to potential confounding variables revealing themselves in the differences between the groups. One way to account for that is stratified randomization. So this creates subgroups or strata that are going to be based on age, disease severity, gender, something that you think is really important and potential confounder in your study to make sure they're equal in the groups over time. Finally, cluster randomization is going to randomize based on entire groups. So if you're doing a multi-center study, you'll see cluster randomization based on each hospital center, okay? And so what this helps with is making sure there's not differences that arise between the different centers because you are doing the randomization within that center, which helps balance out the demographics at each center, and then you can combine the data for a full analysis. With all these design characteristics in mind of a randomized controlled trial, how do you actually go about doing it? Well, you have to do a study design selection, so you need to figure out what kind of randomized controlled trial are we doing. Are we doing a parallel where we give placebo and intervention at the same time? Are we doing a crossover where we have single patients both have intervention and placebo? Are we doing factorial where we might have a double amount of patients on intervention versus only half the amount of patients on placebo? All these we'll see a little bit later. And so this is just one of the beginning considerations. And then we have to create detailed protocols, which generally have to be published online prior to even consenting the first patient. And that's what clinicaltrials.org or .gov, is for. So you can publish your protocol online. And why is this done? Is because we want to make sure investigators are sticking to their protocol. If you start going off protocol, that raises red flags that maybe you're seeing something that wasn't working and you need to change, but then that might invalidate the outcome, because if you're changing things as you go along, you're not sure what real effect you're seeing. Are you seeing the effect of the intervention, or are you seeing the effect of the change? And finally, follow-up implementation, just again what it sounds like. We're making sure we're doing follow-up to adhere to all the pre-specified protocols and study design that we established before beginning the study. Here it is in another variant form showing you how randomized controlled trials go. Population selection, we have to identify and recruit participants, consent them, and get them into the study. We randomize them to a treatment group, okay? Then we follow up on them to look for the observed outcomes, and then we do the statistical analysis to compare those outcomes and report our findings. We went over this in a previous module, but why are randomized controlled trials the gold standard for causality? Because they meet those 3 causality assessments from those big group of causality assessments that we're really concerned with. So we're concerned with experimentation, temporal, relationship, and individual association, which randomized controlled trials meet all 3 of those. They probably meet more than that with Bradford's criteria, but for this class, that's what we're concerned with. And so we can see an example here for the hypertension study we would be working through. The population, and applying PICO to it, the population would be men in Los Angeles. Intervention would be referral to a specialty pharmacist for management. The control would be lifestyle advice and physician referral, okay, so non-pharmacist intervention. And the outcome would be blood pressure comparison between the groups. So that's how you apply PICO to our example that we're working through in this lecture. Despite those rosy glasses of being the gold standard, there of course are limitations to a randomized controlled trial. First being that there's ethical constraints that could arise. And we've talked about this previous lectures as well, but basically there's sometimes you can't randomize patients to certain things like smoking or alcohol and see what happens to them, because that's unethical, because we know that treating people with these types of substances has negative outcomes over time. So we just can't do that. In these cases, we have to use observational studies, retrospective cohort studies, things like that. There's big feasibility challenges with the randomized controlled trials because it takes a lot of people and a lot of money to run these trials, especially if you're doing multi-center. Just think about recruiting a patient, treating the patient, following up on the patient, and doing that over multiple centers on tens of thousands of patients. That's going to get real expensive real quick. And finally, you can just have impractical exposures, meaning that some exposures cannot be ethically or practically randomized. So you might not be able to examine the psychological effects of military combat. Okay, so you can't do that. That's similar to the ethical constraints in terms of the exposures, which we can't just give to patients. I previously mentioned this and how we set up randomized controlled trials, but a key requirement, and this is a requirement by all institutional review boards and the government itself, so when you're doing a randomized controlled trial, not only do you have to get it approved through whatever your institution's institutional review board is to make sure you are doing it ethically, you have to post all your protocols and your way you're going to do the study to clinicaltrials.gov. Okay? This all has to be out this, and this has to be cited in any sort of reporting of the trial from that time on. So anytime you get results and you report them, whether it be a poster, whether it be in the literature, you have to report a clinicaltrials.gov registration, and you will see this in studies that we will see in this class. And the reason that's there is to reduce bias. Again, like I said, you want to make sure the investigators are sticking to their protocols and not changing it up as they go along. What are the components of a study protocol that you would be giving to the IRB and then to clinicaltrials.gov? Well, they'll have the study foundation, so why you're doing it, what's the background, the disease state, how you're going to design the study, how you're going to select the participants, and what types of interventions you're using, the actual logistical implementation details, so what procedures are you using, how you're going to assess for safety, how you're going to report for adverse events, how are you going to statistically analyze the data, so everything. And finally, quality and compliance. This is generally done not through clinicaltrials.gov, but through IRB monitoring. So you have to keep track of everything, every little thing that happens with these patients. I personally had a small clinical trial I did here at Wayne State, and I was audited by the IRB, and I gave the IRB, I think it was 6 huge 2-inch binders that had all of these details in it, and then I had a binder for each participant because that's how much information I had to keep on each one, and they go through it with a fine-tooth comb. We've talked about this kind of here and there throughout these lectures, but how do you actually get participants in your clinical trial? So you have to first set inclusion-exclusion criteria. What patients do you want, and what patients do you not want in your study? And again, these are considered very carefully to reduce bias. You have to think about how you can actually get these patients. How are you going to advertise for them? How are you going to recruit them? Are you going to work through clinics and hospitals and certain doctors? Is that ethical? How do you outreach to them without making them feel coerced? These things are also assessed by IRB requirements that make sure you are not putting overdue pressure on patients to be in your study. You're not overpromising them the potential for positive effects in your studies, and you're also telling them all the risks and benefits. So for example, in my small clinical trial where I gave olanzapine, which is an antipsychotic, to healthy volunteers, so generally college students would be the ones who were in my study, my consent packet was 17 pages long. And so we had to go through in detail with every person that was interested. And it took a good 45 minutes to an hour to tell them all the risks and benefits of just a simple 1-week treatment with olanzapine or placebo in the study. And that just shows you in a small clinical trial with a medication in healthy volunteers how rigorous this process is for population selection and IRB requirements and consenting. And so just think about that being expanded on a nationwide level. What does it actually look like when you're following a patient from beginning to end in a clinical trial? First, you have to screen people. You got to figure out, are they eligible based on my inclusion-exclusion criteria to be in the study? Then you have to approach them. You have to inform them and consent them. And then you randomize them to whatever your study groups are. Okay, and that gives them into a group. And so then you got to figure out how many received it as were meant to and how many didn't in both groups. And then you have to follow up over time. You're going to always lose patients over time from either they don't want to be in the study anymore, or maybe someone dies, or they have too many side effects and a physician removes them. All these things can occur in a study. And then you finally have to do a final analysis. Okay? And what this is called a consort flow diagram. Consort is an acronym for something you don't need to worry about. If you want to look it up, go ahead. But it just basically helps to make sure that all papers are reporting all of these parts of a study so that we can fully assess the validity, the biases, the confounding that might be in a study and be able to better interpret its results. How do you actually select a control group in randomized controlled trials? Really, there's two different ways to do this. You can either do placebo, okay? They receive an inactive substance, usually what they would call a sugar pill, okay? And this helps account for the placebo effect. It gives a true baseline comparison, and it's only ethically appropriate when there's no effective treatment that exists. When there's an effective treatment that exists, you have to give an active control. Okay? And the reason you can do this is you can't withhold treatment from people who need it. And so this generally compares a new intervention, whatever you're studying, to the current standard of care. It's more ethically appropriate when this treatment exists. And you can design these to be superiority, non-inferiority, or equivalence trials, and you will often see this with pharmaceutical companies because if they're not first in on a disease treatment game, they're going to have to compare their drug to whatever is out there. So that's why you'll see superiority, non-inferiority, and equivalence trials, which we'll go into in a future slide and modules. So when you're doing your intervention assignments, you can do these in parallel, meaning placebo and intervention treatment are given alongside at the same time, or crossover, meaning one patient receives both intervention and placebo with a washout in between. So you can see here what are the differences between a parallel design and a crossover design. Group assignment, in terms of numbers, you need a greater sample size with parallel, which is why the bar goes further than crossover. You need a smaller sample size because you're using the same patients. So you're going to inherently have equality between groups because you're using the same patient between placebo and treatment groups. The statistical power is lower with a parallel design versus crossover. Again, you can see the required sample size differences there. The duration is going to be longer for a crossover because you need a washout period. You have to make sure whatever the effects of an intervention are not occurring when you have to cross them over to the other treatment. And then finally, washout period. Obviously, there is no washout period in a parallel design because the groups are separate versus you need the washout period in a crossover design because that one patient is going to receive both treatments. There are a few analysis approaches in clinical trials you need to be aware of because you will see it in the literature. The most common one you'll see is intention to treat because it's considered the gold standard. Basically, this is analyzing patients according to whatever group they were randomized, no matter what happens to that patient. If they withdraw, if they have poor protocol adherence, they cross over for some reason to the other group, that happens. We still analyze them as if they were in the original assigned group, no matter what. And the reason they do this is because it increases the applicability, more external validity, I would say, to real-world conditions where compliance might not be perfect. This is in contrast to a per protocol analysis, which includes only patients who fully comply with the study protocol. Okay? And this might reduce external validity but increases internal validity. And then you have an interim analysis, which basically looks at the outcomes in the study before it finishes to make sure things are still safe, to figure out if they should stop it early because they see a huge treatment effect already. You'll see this sometimes as well. Some other terminology that you need to be aware of when you read these papers are a run-in phase. And so this is considered a preliminary period with all patients are treated with the intervention to see how they tolerate it. And so this is good because it might help protect patients, but it also makes the final result maybe less applicable because you're getting only people that tolerated the medication. So you're basically ruling out a lot of side effects. And then effectiveness versus efficacy. Effectiveness is when we are looking at an intervention's effect only under real-world conditions with diverse populations versus efficacy is more under these controlled, carefully defined conditions with carefully selected participants, therefore what? Increasing internal but decreasing external validity. However, both approaches are very valuable. You just need to know the difference between effectiveness and efficacy. Why are we talking about all this? Why is it so important to know how to interpret a randomized control trial? Because you as pharmacists need to know all these nuances, all the biases, the rigor, the statistical validity, the confounding, in order to appropriately make decisions to apply to, again, real-world people that are going to have real-world effects. So a framework that we can use to figure out clinical trial quality is called the Marie model, or the Mary model, maybe you want to call it that. And basically it's an acronym that'll help you figure out how to assess a clinical trial step by step, starting with methods, assignment, assessment. So methods: purpose, population, study, sample size. What is the study hypothesis? What is the population being investigated? These are the questions you need to ask, okay? Is the sample size adequate? Assignment: how was it allocated? How was the randomization used? Was it adequate? Were the groups, investigators, participants, analyzers blinded? Assessment: how did the outcomes get measured? Is it appropriate? Was it objective? Could there have been a better assessment? All these questions you need to ask under this model. Continuing on with the Mary model, we have results, interpretation, extrapolation. So results, comparison of the outcomes. What is the magnitude of the relationship? We're going back to this previous kind of skills we've already learned about. Are they statistically significant? Should there have been confounding that was adjusted for, or a stratification analysis employed? Interpretation: what does this actually mean for study participants themselves? Did the intervention actually produce undesirable or desirable outcomes? What were the adverse events? Did the outcomes differ in subgroup analyses? Finally, extrapolation: what does this mean for actual clinical patients you are going to treat? Do these conclusions apply to similar patients or even more broadly? Are the investigators to extend these conclusions beyond the study parameters? So does this have potential effects in different populations or on different treatments? All these questions that you need to ask to be able to adequately assess a clinical trial with the Mary model. So let's go through a randomized control example here with what's called the barbershop study, which kind of applies to what we were looking at and trying to answer the question at the beginning of this lecture, looking at non-Hispanic Black men and the effect of pharmacists on blood pressure control. So we found a reference. Here it is. It's in the New England Journal of Medicine. The null hypothesis from this reference was Black men who see specialty trained pharmacists will not have better blood pressure control than men who are not referred to specially trained pharmacists. Again, sounds goofy, but that's the null hypothesis. Basically, this means that when you have a pharmacist trying to achieve blood pressure control in these patients, it's equal to the control group. The alternative would be that Black men who see a specialty trained pharmacist will have better blood pressure control than the control group, and you can see that there. They have lower blood pressures. That would be the alternative hypothesis. So after you figure out the hypotheses of a study, you need to figure out, did they actually get the population they wanted to? Did they target the right population? And so they really wanted to look at underrepresented Black men in this clinical trial. So the Mary framework asks us to examine what population is being investigated. What are the inclusion-exclusion criteria? If we were to look up this paper, we could see that they were looking at non-Hispanic Black men from barbershops in Los Angeles County with uncontrolled hypertension defined as a systolic blood pressure greater than 140. And they had to be regular customers so that they would be coming back every 6 weeks, right? And a key exclusion criteria were dialysis treatment, hospitalization for unstable angina, heart attack, stroke in the previous 6 months. The population selection strategically addressed a healthcare disparity while leveraging existing community relationships, so it seems like it might be fairly appropriate for what the hypothesis they are trying to answer. Continuing on with the Mary model, we can figure out that the randomization method used in the study was cluster, okay, where their entire barbershops rather than individual participants were randomized to either the pharmacist or the control group. So it occurred at the barbershop level, which is why it was a cluster, okay? Prevented contamination between intervention and control groups, and it leveraged existing community structures. And in terms of sample size, generally, sample sizes are covered at the midterm of a study. You've tried to figure out, are we reaching our sample size? However, when we're doing cluster randomization, this requires larger sample size than individual randomization to achieve equivalent statistical power. And this is really because participants within clusters tend to be more similar to each other than to participants in different clusters. So the researchers needed to account for this in cluster correlation analysis when determining the necessary number of barbershops and participants. So all those things need to be considered when determining a sample size for this specific study. So what actually happened in terms of the breakdown of the groups in a confounder analysis. Okay, so despite randomization, the barbershop study kind of reported some important confounding variables. For example, high cholesterol was significantly more common in the intervention group than the control group, with a P of 0.04. So this difference could potentially influence blood pressure management, and so should be accounted for in the analysis. But you can see here the other factors that are presented, diabetes, smoking, and family history, were fairly similar between the groups and likely don't need to be confounded or accounted for as a potential confounder in the outcome. What about blinding and the assessments used in the barbershop study? So the blinding, it was an unblinded study, and this was due to the necessity of it being unblinded. You can't figure out how to blind people to a pharmacist versus control scenario, so necessarily it was unavoidable, and so then it introduces the potential for bias that we really can't help. However, the outcomes were fairly appropriate. So the primary outcome, the change in systolic blood pressure from baseline to 6 months, was directly measured with a blood pressure cuff. And so this is an objective physiological measurement. It was standardized using automated devices to reduce variability. So the assessments were quite strong in this study. What about the potential for bias due to dropout? In the barbershop study, they actually had remarkable retention. They had 95% retention. They had zero difference in the attrition or the dropout between the groups for a total of 319 participants. So this is excellent. It really reduces our concerns for any sort of attrition bias or loss to follow-up bias which could occur, because sometimes you can see that there's greater loss to follow-up in the intervention group versus the placebo, which immediately should give a red flag that perhaps there's side effects in the intervention group that we need to be looking at. So this really strengthens the confidence in the study's internal validity. Now that we've gone through all the other parts of the study, what about the actual results? So the magnitude of the effect in this study from the paper was a mean reduction in systolic blood pressure in the pharmacist group of 21.6 millimeters of mercury. The 95% confidence interval, which tells us with 95% confidence that true value falls between 14.7 and 28.4. When you compare that to the control group's reduction of only 6.7 millimeters of mercury. So the 21.6 really represents a clinically significant improvement with the potential to substantially reduce cardiovascular risk. And we know that this is clinically meaningful because the confidence interval does not contain 0 or even contain the control group's reduction number. It's substantially higher than that, suggesting that pharmacists indeed can have a big effect on black men's reduction in blood pressure through this barbershop method. We do need to make sure that the statistical analyses were appropriate for that outcome we just mentioned. And so if we were to look at the paper's statistical methods, you would see they listed a linear mixed effects model, which is a type of regression or multivariable regression analysis. And this was really good because it was able to account for cluster randomization, so it was entered in as a variable into the model, along with confounders like the cholesterol we talked about was entered in to the model, and it allowed for repeated measures over time. So it's an advanced statistical technique, but it's a really good and powerful technique that lets you account for clustering, confounding, and repeated measures over time. So we know that it's robust and very strong in terms of how they analyze the outcome. We can be pretty confident in it. As we come to the final two steps of the Mary framework, we need to interpret the study results for the patients themselves. And so really there seems to be a significant effect of pharmacists with a fairly clear causal relationship that they can reduce blood pressure more meaningfully and in a more statistically significant way versus a control measure. In terms of the safety assessment from the paper, there's really no differences in adverse events between the intervention and control groups, suggesting that the pharmacist-led approach was safe. And subgroup analyses were not reported in the study, but maybe we could have thought of some that might have been reported if there were certain other factors, maybe if there was more than just men included in the study. So that's not really consideration here. So what about the understanding of this barbershop study to populations at large? And so the authors in the paper do suggest that maybe this type of approach might be useful for other hard-to-reach populations using a unique approach, such as through a barbershop type method. However, they were cautious and did not over-interpret their findings, suggesting that this could be done for everyone. Okay, it can't work for all demographic groups, but maybe something unique like this can be applied to other demographic groups as well. So the Mary model, as you can see, can be applied to any study, but we just applied it to this barbershop study, which is really useful because it helps give us a framework to know about the study quality and applicability. Now let's use this barbershop study and apply it to our previously learned PICO and Rambo-Mann methods. The PICO is pretty straightforward, as it always is, and we already went over this in this lecture, but the population, non-Hispanic black men who frequent Los Angeles barbershops. Intervention was pharmacists managed blood pressure care with medication prescribing and $25 gift cards for prescription and transportation to help keep them in the study. The comparison was physician managed blood pressure with lifestyle recommendation from barbers and advice to seek physician consultation. The outcome was reduction in systolic blood pressure from baseline to 6 months, and the time frame was again 6 months in Los Angeles County. What about looking for bias through our Rambo-Mann framework that we talked about previously? Well, for this study, for recruitment and assignment, the barbers were recruited across different groups, minimizing selection bias, though the narrow population may not represent all non-Hispanic black men because we're only looking at barbershops. The assignment was cluster randomization, so it created mostly balanced groups at baseline, so that's pretty good. Maintenance and blinding, what about that? The maintenance, there was high cohort retention, so that was really good and reduced follow-up or attrition bias potential. However, the blinding there was none. So even though this was pragmatically necessary, it could have influenced the outcomes and the patients knew what group they were in. And then finally, for objective measures and analysis, were the measures objective? Yeah, they had a standardized objective measurement of blood pressure with automated cuffs. And the analysis was done with intention to treat. Remember, we talked about that earlier, meaning that whatever group they were assigned to, that's what group they were analyzed in. And so they were analyzed in probably the most robust and advised way for randomized controlled trials with intention to treat analysis. It's always good to look at the patient flow in a study to figure out if it's appropriate. Maybe if you have high attrition rates, what went wrong in a patient flow. Here we can see in this barbershop study, they screened potential participants across multiple barbershops, identifying men with uncontrolled hypertension who met the inclusion criteria. Then they cluster randomized them, so they, again, randomized barbershops rather than individual participants to either pharmacist or control intervention to prevent contamination between groups. Okay, because if you thought about randomizing individual participants at the same barbershop, they would be talking to each other, and then you would have contamination in methodology and information. And then this achieved exceptional retention in the study with 95% of the participants staying in the study to its conclusion. Now let's go ahead and do a validity assessment for this barbershop study. What about the strengths? What internal strengths were there for internal validity? Well, they had really low random error because they were statistically significant. The results were p less than 0.001 with a very big and strong confidence interval, I would call it. Not a big, I would say a 95% confidence interval that showed that the true value remained very large. That's how I wanted to word that. Far from the null of 0 millimeters mercury. The confounding control differences to baseline and cholesterol were assessed using that linear mixed model that we talked about. And the causal criteria. This is a randomized controlled trial, so it shows that experimentation, temporality, and individual level associations that we want to check off. So the causal strength is really, really strong here. Random allocation, temporal, individual participants, large effect size, and biological plausibility of the intervention all give credence here to having a strong causal effect of pharmacists controlling blood pressure on the patient's blood pressure itself. So if you had to render a final evaluation of the validity, you'd probably say high for internal, okay, despite some limitations, like keeping people in the study with $25 vouchers probably really helped keep the retention. That might not be as plausible or feasible in a real world setting, okay, versus the control group only received lifestyle recommendations. But the external validity is probably relatively low, which was a purpose of the study, right? Because they're really only trying to get non-Hispanic black men, and so it's really only valid for that population, especially valid for non-Hispanic black men who frequently get haircuts. So the external validity is probably pretty low here, but still, again, a very good study and with important results. All right, so that concludes your lecture on randomized controlled trials. I think as we go forward here, I want you to review these concepts so that we can apply them to randomized controlled trial analysis and then transition that into clinical decision making, okay? So all the things we talked about today, the validity concepts, the different types of terminology, you need to really know these in order to apply them to many studies going forward, and this will be essential to you performing well on the exam too. Thank you.